Welcome to this UCL lunch hour lecture on unequal mental health, society, power, and the depressogenic environment. My name is Sam Bolsh, and I'm the Director of Grand Challenges at UCL, and I'll be chairing today's lecture. World Mental Health Day is recognised annually on the 10th of October. This year, Workplace Health is running a campaign that aligns under the Healthy Mind theme of being well at UCL. This year's theme is Promote, Prevent and Support, prioritising mental health in the workplace. As part of the campaign, Workplace Health and the Grand Challenges have collaborated to bring you 4 lunch hour lectures on a range of topics relating to mental health and some of the challenges that are faced across the mental health landscape. These talks embody the whole university approach towards mental health support, outlined in the recently agreed UCL mental health principles. These principles are the next strategic step to creating a healthy culture for both staff and for students here at UCL. Today is the 3rd talk in the series, and it's my honour and pleasure to introduce today's speaker, Professor Pravita Pathole. Pravita is Professor of Population Health and Wellbeing at UCL. She holds a joint appointment between the Department of Population Science and Experimental Medicine, the Faculty of Population Health Sciences, and the Centre for Longitudinal Studies in the Institute of Education. Her research focuses on mental health through the life course and drivers of health inequalities, with an interest in examining these across different global contexts. She is interested in how we can achieve better health and well-being through our lives and the preventative measures and structural changes that might be needed to support this. She leads a multidisciplinary research group at UCL and is working towards improving the diversity of disciplines, individuals, and countries represented in mental health science, with the goal to accelerate progress in improving population mental health. Before we begin, I wanted to let you know that we will have some time at the end of the lecture for questions, and these can be submitted at any point during the talk by going to Slido. You should have the link to Slido within the invitation, and entering the invite code, the event code, #equality. I will now hand over to Pravita for her talk.
Thanks, Sam. I'm just going to share some slides. Hi, everyone. It's a real pleasure to be giving this lecture. When I was a PhD student at UCL more than a decade ago, I used to always pop in and attend the lunch hour lectures, and I never thought there'd be a day where I'd do one of these, so I'm really excited to be here. So today my talk is going to be, as Sam said, about unequal mental health and understanding the role of society, power, and the depressogenic environment in the mental health crisis we see today. So mental ill health is one of the largest causes of global disease burden. The most common mental health conditions, which are depression and anxiety, are the leading cause of disease burden in most countries in the world already today. And apart from the real large amounts of suffering to people and their loved ones that mental ill health causes, mental ill health also has a lot of sort of wider consequences, including to the economy and society and so on. What most people don't realize is that most of us will experience poor mental health at some point in our lives. According to the best estimates we have that follow the same people across their lives, around 85% of people at some point until midlife will experience mental health conditions such as depression, anxiety, or something even more severe. And for a majority of people who experience poor mental health, the onset is in adolescence. So for 80% of people who experience some mental health condition in their lives, the first experience of this is before the age of 20. And this is one of the reasons why most of my research, but also the examples I present today, will focus on adolescence, because this is the period where most onset happens. It is also the period which is most ripe for prevention and thinking about intervention. And because most people experience mental health conditions so early in life, there's consequences throughout the life, including on a whole range of different domains that are important for people's lives, including their educational outcomes, their economic outcomes, partnership, family formation, social outcomes, but also later health. So obviously, mental health is associated with later chronic health conditions and also early mortality. And the experience of mental ill health is unequal by many, many dimensions, including, these are some examples, sex, economic circumstances, disability, geography, sexuality, ethnicity. And obviously, most of us don't belong to just one of these things. And so even the disadvantage or the inequalities in mental health are sort of interconnected. So the overlapping sort of categories that we sort of experience also have overlapping impacts on our mental health. And the important thing about this is also to think about, because, as I said, mental ill health starts so early in life for many of us and has implications for other outcomes. There's also a cycle of how poor mental health impacts on, for example, our educational outcomes, and then the poor economic circumstances, for example, then impact on worse mental health. So there's also a cycle where inequality begets more inequality in mental health within our lives. So the socioeconomic inequalities in children's mental health, for example, are much narrower than the socioeconomic inequalities in older people's mental health because of this cyclical vicious cycle where poor mental health leads to poor other outcomes, and poor other outcomes lead to, again, yet more poor mental health. And often it is sort of talked about as a sort of inequalities based on minority status. You often hear, I have been, for example, told that, of course, ethnic minorities in the UK would have worse mental health because they're a smaller group, and the group that is smaller is the outgroup and has less power and hence will have poor mental health. But I just wanted to illustrate that it's not just about numbers and not being a smaller group. This is an example from the UK where we see that Black people in the UK have much worse mental health on average than white people in the UK. But obviously the proportion of the population, white people are around 82%, whereas Black people are around 4.2% of the population. But comparatively in South Africa, it's the same pattern in mental health where white people in South Africa have much better mental health on average than Black people. But in South Africa, 80% of the population is Black and 8% of the population is white. So just really highlighting that it's not about who is a smaller group in society. It's about which are the groups with less political, social, and economic power. And the most stark example of this that will be quite universally present is gender. Although women make up half the population, thereabouts, give or take, in most societies in the world, on average, women have much worse mental health than men. And this is true for lots of different mental health outcomes. So in this particular graph, this is an example in 17-year-olds in the UK, where we see that they, on average, have worse psychological distress. And psychological distress is just symptoms of depression and anxiety. But also if you see prevalence of certain conditions, so, you know, the likelihood of self-harming or attempting suicide, girls are much more likely than boys to have self-harm, to have attempted suicide by age 17. And to really highlight, because often with the gender gap, the assumption is that this will be or might be fully biologically explained. So, you know, hormones are different and hence girls have worse mental health than boys. However, there's lots of evidence that indicates that this is unlikely to be the case. And one piece of evidence I will offer in terms of trying to make this argument is that the gender gap itself really varies quite dramatically across countries in the world. This is an example in around 70 countries. And you can see the gender gap varies from being almost non-existent or really small to being quite large. And if it was a purely biological thing, then it should really at least be seen consistently everywhere in a similar magnitude. And to try and think about power and gendered risk factors, I'm going to give an example of sexual violence. So most victims of sexual violence are women and most perpetrators are men. And this has been true for centuries and is true in most parts of the world. And this sort of power imbalance has existed for a long time, and the legal, political, and societal systems we have don't do anything to try and change this. So even in a country like the UK, where we'd have, you know, good legal systems, arguably compared to lots of the world, and police and so on, sexual violence against women is still treated as a fairly so there's lots of victim blaming. So in one hand, women don't get are not taken as seriously by the system, don't get the support they need, and the system still continues privileging men, and there's very few perpetrators are ever actually prosecuted for crimes against women. And just to highlight that even by adolescence, so this is data from mid-adolescence, the differences in the experience of sexual violence really vary. So boys on average experience sexual violence. 1% to 5% of boys report experiencing any sexual violence by age 17, and comparatively, this is 20% in girls. So about 4 to 5 times as much of sexual violence in adolescents in girls compared to boys. And unsurprisingly, sexual violence is associated with poor mental health. So this is an example, again, in the same national study I showed data from earlier, where we see that young people who experience sexual violence between 14 and 17, and here on the left side, you have their mental health, these two groups at 14, both in girls and boys, more likely at 17 to have worse mental health outcomes, whether it's higher psychological distress, more likely to self-harm, and more likely to attempt suicide. So really clear impacts of sexual violence in both boys and girls. However, as highlighted by the previous slide, because this experience is more common in girls, obviously the impact of this is much higher on the population level in girls. So the next type of inequality I want to talk about is in geography. So this is a world map that is shaded based on the population of each country. And as you can see, there's countries that are really dark, China and India, and there's countries that are really light. And this is just sort of reflecting the range of population sizes. And this is where most of what we know about poor mental health, how it develops, the causes, the consequences, and so on, come from a very small number of mostly high-income countries that are white majority in Europe and North America and Australia as well. And this is a problem because what we think we know about mental health, we actually know about mental health in like a handful of countries. And actually, we know very little about whether this translates or is generalizable to the rest of the world where most people actually live. And when you focus on young people, this inequality becomes even more stark. This is a really nice graph from just RCTs, so randomized controlled trials of treatment interventions in low and middle income countries versus high income countries. And it's a sort of 10-90 split. So you can see that 90% of controlled trials in young people are conducted in high income countries, whereas 90% of the world's young people live in low and middle income countries. So 90% of the world's 1.3 billion adolescents live in South America, Africa, and Asia, but almost everything we know about how mental health develops, we know from Europe and North America. And this has lots of risks. It risks incorrectly applying knowledge from a small subset of high-income countries to the rest of the world, which means that it's possible that a lot of what we know about mental health we don't apply and has very little impact on improving the mental health of most of the world's adolescents. And this is also not helped by the fact that research capacity in mental health sciences in most of the world is very limited. And as a result, like even really fundamental questions of risk factors, causes, and consequences might be different or may not across contexts, but we just don't know. And I'll just give an example of a research study asking a fairly, you might argue, simple question about economic circumstances and suicide attempts. And in this study, we looked at food insecurity and suicide attempts across around 70 low and middle income countries. And what we find, which is really stark, is that there is an effect. Obviously, food insecure adolescents are more likely to have worse mental health than food secure adolescents in most countries. Actually, in this case, we see that in some countries, we don't see a significant association. But the effect size, so how much food insecurity matters to mental health, really varies across countries, indicating that there's contextual factors about the wider context, how society is structured, how families might be structured, that buffer to different extents the impact of something like food insecurity on poor mental health. And the next inequality I want to talk about is research focus. So in mental health, like it has been recognized for most of health for at least the last 30 to 40 years, there's this idea of the biopsychosocial model, which is basically that biological, psychological, and social and environmental factors all come together and contribute to sort of causing poor health, and in this case, poor mental health. So this model is accepted widely as being necessary and useful in mental health sciences as well. However, the reality of how we study mental health for the last couple of decades has really sort of prioritized the biological and psychological and left very little interest in the social and environmental. And this was really driven in a very clear manner by the National Institutes of Mental Health in the US, which is one of the biggest global mental health funders, where they had this ad hoc framework in the early parts of this century. And really the focus of that was to try and provide a framework for classifying mental disorders based on genetics and neuroscience, and to define mental health as sort of brain disorders. And this really swung the pendulum in favor of lots of research into genes and brain correlates of poor mental health, and very little interest left in the social and environmental. And this had real impact on how science is done. When I was earlier in my career, the running joke used to be that if you want to get any funding for any question, you have to have some amount of genes or brains in there to get the funding. Otherwise, you're not going to get any funding. And the reason this is counterproductive to lots of what's happening in the world right now, I think, is I'm going to present the case of worsening trends. So essentially, in most countries where we have data to look at this, mental health in every generation is worse than the previous generation. So there's greater levels of psychological distress in young people in the 70s compared to in the 1960s, in the early 2000s compared to the 1990s, and now compared to even 10 years ago. So essentially, mental ill health in young people, but also in adults and all other generations, is generally getting worse. And the thing that we all know is that genes and biology do not change at this pace. Our genetics don't evolve that quickly. The biological systems don't. So they are not plausible explanations for these increasing trends. Obviously, genetic liability matters. So people who are more genetically susceptible to poor mental health will be more likely to experience poor mental health in a worse environment compared to in a not worse environment. But the genes itself are not changing. So the explanations for these worsening trends have to be environmental. And in this sense, I think thinking about the depressogenic environment or the features of the environment that might help explain worsening population mental health is really potentially useful if we're going to have to do something to sort of turn this tide of ever increasing and worsening poor mental health. And not only is mental health getting worse overall, inequalities in mental health are also widening. And this is data from the UK comparing four generations born in the 50s, 70s, 90s, and early 2000s. And as you can see in this graph, the sort of gender inequality hasn't changed across these four generations. So women have always had worse mental health than men, but the size of this has remained consistent. But some of the economic differences in poor mental health in teenagers has changed already in these four generations, indicating that in more recent generations, the economically worse off have even worse mental health relative to the economically well-off teenagers compared to 40 years ago. And not only this, the consequences. In the beginning, I started by saying mental health in adolescence has a whole host of lifelong consequences, such as poor educational outcomes, poor economic outcomes, and so on. And these consequences are actually, from some evidence we've seen across generations, worsening. So not only are more people experiencing worse mental health, it's possible that their impacts on later life are also getting worse. And there's lots of trends that happen in parallel. These trends don't occur in isolation. And I'm just going to give one example of social isolation as another thing that is changing across generations. in this particular study, we report on various different dimensions of social isolation. And in this graph, I'm just showing the probability of living alone across 5 generations in the UK. And as you can see, with every more recent generation, the probability of living on your own is increasing. And living on your own or social isolation is associated with worse mental health. But there's lots of other trends that are relevant to mental health that are happening in the last 70 years. For example, sleep is worsening. There's increasing weights in many countries. So on average, BMI is increasing, but also the proportion of the population that is overweight or obese is increasing. Social mobility is changing. Opportunities are changing. So there's lots of sort of changes that are happening in parallel that I think are useful to try and understand which of them might contribute to the sort of worsening depressogenic environment. And even when we do examine social determinants, usually they're very limited. The most commonly studied social determinants, I think, are economic position, gender, ethnicity or race, sexuality. And in the global context, again, taking sort of a step back from the few countries in Europe and North America that we tend to study, there's many other ways people are minoritized that are relatively understudied despite affecting large proportions of the global population. And just as an example, religion. So for example, we know very little about minority and majority religion differences in mental health, caste, and this is relevant specifically to the Indian context where I'm from, migration. So there's lots of things that we don't actually have very good evidence on, and macro aspects. So thinking about policy and how policy changes affect mental health, societal beliefs. So for example, in many Western democracies, the people believe in a meritocracy, where the idea is that if you work hard, you will sort of do well. And there's lots of evidence that although people believe this, it's not true. And there might be mental health impacts of that. There's commercial determinants. There's lots of sort of commercial players at play in terms of what food we eat, what we consume, sort of the waste we create and so on. And obviously more and more the climate change. So these things that are even less studied than some of the other things that I've mentioned. And I think are probably all important things to try and understand if we really want to understand why there's these worsening trends in poor mental health across the world. And in terms of intervention, there's also an equal focus on how we intervene. And this, I mean, it was just a nice quote because I couldn't have put it any better. The blame for systemic failure is individuated, and intervention is very much targeted at the individual. And lots of the time it's positioned as individuals versus society or environment. In this case, we do most intervention with individuals, but there's also other considerations here. So for example, lots of intervention is downstream versus upstream. And just to highlight this, so for example, there's lots of focus on improving physical activity. And true, like you could try and make people be more physically active, and that would be better for their mental health and for their health in general. However, there's no corresponding focus on upstream policies like better spaces for physical activity and better safety. As we know, there's lots of evidence suggesting that, especially for women, physical activity engagement is linked to safety. And if the streets are not safe, they're less likely to be physically active. So at best, if you only focus on trying to make people exercise more without trying to fix any of the things in the environment that might help them exercise more, you end up in a situation where at best any efforts to make the individuals change behavior will have some short-term impacts, but will not sustain. And this also relates to the next point, which I have on the slide, which is short-term versus long-term thinking. So lots of the individually focused things, I think, reflect a short-term way of thinking, because if you really wanted to tackle the environment and prevent mental health problems, you wouldn't possibly see all the impacts of this immediately. And you'd have to want to change things slowly over long term and be happy to see the impacts long term to do lots of these things that might help. And so I think moving to a world where we do both the individual focus on individuals and society and environment, downstream and upstream and short term and long term, is sort of a helpful way of thinking if we have to sort of make long term changes in changing these worsening trends across time. And this really reflects in how sort of what mental health interventions are funded currently. So the Wellcome Trust, which is again a very big funder, probably the second largest mental health funder in the world at the moment, decided that mental health would be one of their areas of focus for the next few years. And these are the things they've been funding. They published sort of a list of what they call active ingredients. And as you can see, there's a lot of things about, helping people problem solve and regulate emotions and knowing how one feels and controlling emotions and sense of mattering and agency and so on. But there's very little in here about actually trying to change or fix or understand the role of wider social factors or environmental factors. The only ones I could find are the ones that I've sort of highlighted in red. So economic transfers, urban access to green space, and maybe neighborhood cohesion. But other than that, all of these dozens of things are related to people and doing things to help the individual, which are all really important. But I think, as I just said on the slide earlier, I think you also have to combine that with things to change the environment. And one of the issues with this strategy is one of the reasons for why these are focus that was given is that these are things with some evidence behind them. And they only wanted to focus on things that have some evidence behind them. And that sort of leads to the other problem, which is if nobody funds the wider social and environmental things, there's no research or there's no evidence, and then nobody funds it because there's no research evidence. And then we're stuck in this vicious cycle where we have very little resources to try and understand the social and environmental determinants of poor mental health and how they might be used to prevent worse mental health. And the last sort of unequal thing I want to really stress is treatment access. So even if, we had perfect treatments, enough capacity in the health system for treatment, who accesses treatment is very unequal. So first of all, availability of treatment is very unequally distributed by place. So even in a high-income country like Britain, there is not enough availability of formal mental health services. And in the rest of the world, there's countries in which the number of mental health clinicians per 100,000 people in the population is really, really tiny. So formal treatment is just not a viable option right now for most of the world. Even where it's available, there's large inequalities in who accesses these and how. So for example, there's inequalities by socioeconomic position, there's inequalities by ethnicity. So this is an example on the picture I have on the slide. It's an example of research we did here in the UK, which indicates how children with similar levels of problems access child and adolescent mental health services. And what we find is that the sort of more voluntary routes via primary care or self-referral are much more likely to be used by white British young people, and sort of the more compulsory or routes via social care, youth justice are more likely to be sort of accessed by ethnic minorities. And this is a problem because it indicates that the sort of availability or access to treatment, formal treatment, is not equal across groups. And it's not consistently or universally effective either. So there is evidence that formal treatment, it doesn't have 100% success rate. So even if you do, for example, talking therapies on average, help around 50 to 60% of patients who access them, and for the rest, they either sort of maintain things as is or can even deteriorate symptoms. So I know I've run through a lot of different ways in which sort of the experience of and the science of mental health is very unequal at the moment, but I'd like to take a step back now and sort of imagine a scenario. So imagine we were all hanging out in real life in a really, really cold room. And in this really cold room, some people will feel colder than others, but everybody on average is sort of a bit miserable. Some have greater susceptibility to the cold. So for example, we know that women tend to feel colder than men on average for any particular temperature. Some people will be genetically more susceptible to the cold. Some people will have health problems. But overall, everybody's feeling a bit miserable, but some people are feeling even worse than others. And the current scientific approach to this, to seeing this, is to try and do this. So we say, let's study which genes make you feel more cold, or what is the biological response to this cold, or what are the drugs that could help you feel less cold, or maybe we can get people to exercise and that will warm them up, or meditate. So essentially, our current scientific approach to this very cold room is to look at these various sort of biological, neurological, and pharmaceutical solutions to the cold. And in practice, how we deal with this in terms of the actual cold people in the room is we say, why don't you run around and jump around and exercise so you feel warm, or eat warm food and drink that will help you feel warmer, or wear more clothes, or take the right pills, and you will feel warmer. And the issue with all of these things is they require resources. So what ends up happening is that the people who are able to jump around, eat food, or wear more layers are the people with greater social, economic, and political power. And this is how inequalities sort of establish and further entrench themselves. And the issue with this is, if you asked anyone, even like a child, I have actually tried this, what to do in a scenario where you have a freezing cold room, is they would say, find ways to warm the room up. And if you manage to find ways and to warm the room up, not only are most people then comfortable, the inequalities in who is cold and comfortable will also be narrower. And of course, even in the scenario, there would be some people who will still feel the cold because either due to illness or genetic susceptibility or so on. But then the individually focused solutions, such as the pills or the clothes, would be needed by a smaller group of people. And generally, everybody, even the people who are still feeling cold, would feel much better overall. So going back to mental health, imagine this is the distribution of population in the population of psychological distress levels. And we can see there's people with very low psychological distress and there's people with high psychological distress. And then we have, imagine a severity beyond which you also have individuals who need specialist support and treatment. So this is like diagnosis such as depression, anxiety, and so on. And currently what's happening over the last few decades is, because of the depressogenic environment, mental health is getting worse. So everybody's mental health is just getting worse, which means that also there's more people now on the right side of this red line. So there's many more people who need specialist treatment, but also more people who are generally just feeling more miserable than they were 50 years ago. And if we could do something to shift the distribution back left and tackle the depressogenic environment, not only would everybody feel a bit better, also the number of people who need specialist support here will be lower, which means that actually we can focus on the people who have sort of greater levels of distress, and the health service and stuff will be able to support them. But then generally, everybody will have better mental health and better well-being and will live more fulfilling lives. So tackling the depressogenic environment not only improve mental health for everybody, but it also could reduce inequalities, as the negative impacts of sort of the depressogenic environment often worse for those who are already disadvantaged, like we saw from the example in the cold room. And to just really highlight this, going back to the example of sexual violence in young people, if we imagined a world in which we eliminated sexual violence experiences in mid-adolescence, this is what would happen to the rates of high psychological distress, self-harm, and attempted suicide we see in the UK at the moment, which are not small differences because of the large numbers of young people who experience this and the large impact on their mental health. So just to give the example in real terms of self-harming in girls, by these estimates, around 95,000 fewer girls in the UK might self-harm every year if we could eliminate or reduce sexual violence experiences in teenagers, which is not a small number. And obviously this is true for boys as well, but because boys overall experience less sexual violence, there is a substantial decrease in them as well. But overall, there's also, you can see a reduction in the gender gap. So not only is everybody's mental health better, because of the relative impact on girls versus boys, it also helps reduce the inequality we observe between girls and boys. But this is talking about prevention, and prevention is always harder because it's really hard to know and quantify what you stop from happening. So the hypothetical scenario of if we made this better, these are the numbers of people who are depressed or self-harm that we won't see anymore, is always a really difficult case to make. In the case of mental health, I think it's an all sectors issue. I once read someone called mental health and climate change both wicked problems because they're so complex and involve so many things that even the solutions to them need to be multi-domain and cross-sectoral. And in the case of mental health science, they need to be multidisciplinary. So, just one or two disciplines of the neuroscience and psychiatry are not going to solve mental ill health. If we really want to think about it as a population level improvements in mental health, we need people who work in economics and sociology and political science, and all sorts of disciplines need to approach this and consider this a problem that they can help solve, I think, if we really want to make big advances in population mental health. And prevention, in its essence, really is identifying and increasing protective factors in the environment while reducing risk factors. I make that sound very simple, but there's lots of things that are bad for our mental health and lots of things that are good for our mental health. And if we can learn to identify them, do research to identify them, and understand what the levers are to change them, then really you would be trying to do both, increase the good things and decrease the bad things. So in practice, what could this look like? And this is me trying to end on a hopeful note. Include mental health at the heart of decision-making. I think thinking of the mental health and well-being consequences, whether negative or positive, of every planned policy or intervention would be one way of trying to make mental health something that all departments and everybody considers. And this has been done in some countries already. So for example, New Zealand now has, alongside GDP, also thinks about well-being consequences of every policy. I think focusing on the social and environmental drivers of poor mental health and leveraging these to improve population mental health would be a really important step. But to do this, we also have to do more science to understand what the social and environmental drivers are, and considering action at multiple levels, including, so beyond the individual, so that's still really important, but considering action at also other levels, including community, social policy, environmental and commercial and so on, would be really important. And this is possible. So for example, the government in the UK is recognizing this more. And for example, there was recently a UK government prevention concordant for better mental health that schools, NHS, local authorities and stuff are able to sign up to, which presents lots of these things. But obviously this is sort of a first step, and lots more needs to be done if we really have to see changes in the sort of upward trends we're seeing in population mental health at the moment. So the hopeful note to end on is, I think if we try, we can create a less depressogenic environment. And I'd just like to end by thanking everyone that I've ever had the privilege to work with. I tried to start naming people, but it was like 5 slides worth. So this is me thanking everyone I've ever had the pleasure to work with. And also because it's a talk about mental health, I've just linked to some resources if anybody wants to find out more about support available. The first one is more specifically UCL-based resources, and the other 2 are more wider resources for mental health. And I'd also like to thank UCL Grand Challenges and UCL Minds for inviting me to do this talk. And I'd also like to thank various funders who have funded my research over the years. Thank you very much. And I look forward to questions.
Great. Thank you so much, Pravita. That was really interesting. There was a lot that you covered there. And I particularly liked the reference to the fact that we need to look at this kind of wicked problem in collaborative interdisciplinary ways, and particularly if we're thinking about systemic kind of longer term changes, that they go far beyond sort of classic disciplines that have looked at issues around mental health. So that was really good, and a nice link through to the grand challenges as well there. I've had a steady flow of questions coming through during the conversation, and I would encourage people to continue to add questions to the chat, and I will try and endeavour to work my way through them and ask as many of them as possible. So I might start with one that's come in quite recently. So you mentioned New Zealand as a good example in terms of countries that are thinking about and responding to some of the challenges. What other countries are addressing these problems well that you think we could learn from?
Oh, that's a really good question. I don't think I have a really good answer to this, in the sense that I don't have a good overview of what all of the world is doing. I think there's probably things to learn from different countries that are different. So, for example, some countries have much more prevention mental health support in schools. So, for example, Sweden, each school will have a trained mental health nurse, and that's been the case for many years now. There's sort of countries in which there's obviously better social net, which means sometimes that pressures such as academic pressures or economic pressures might not be felt as strongly for poor mental health compared to in countries where that's not the case. There's countries in which sort of social connection or like community cohesion is better, which can also then buffer against poor mental health in the face of adversity. So I think it's a difficult question, and I don't have a better answer than that for this.
Oh, it's good. I think you offered quite a lot of examples there implicitly. So another thing, earlier on in the talk, you were talking. You sort of showed a graph, and you showed sort of the gender gap in terms of, and you showed it broken down by countries. And what I thought was quite interesting about that is actually a lot of the countries that seem to have the biggest gender gap seem to be European countries. Do you know why? Why do you think this might be the case?
There's a lot of interesting sort of literature around this, especially from like sociology and things on social comparison and stuff like that. So I think the two explanations that are hard to like empirically study, but have been offered in the literature are one around social comparison. So there's this argument that in more gender equal societies, girls and boys don't compare themselves to just, so girls might compare themselves to just girls in less gender equal societies, whereas girls would compare themselves to everyone in more gender equal society. And then there's the expectations versus reality trade-off, which is lots of us, actually, even me growing up, I assumed my mom's generation and grandmom's generation had fought for gender equality. And then I was going to, finish school in a gender equal world, which is obviously not the case. The gender pay gap, and even in a country like Britain, is not expected to close for another 100 years. And so I think if you grow up expecting to be treated equal and then you're not treated equal, it might be harder for your mental health than if you grow up not expecting to be treated equal. So there's a few other explanations as well in the literature around this. The really important thing to flag is when people look at country level gender equality and mental health, is there actually aren't any countries that are gender equal. So it's very hard to know what happens in the hypothetical world of a gender equal country to the gender gap in mental health. And it's just, it's one of those things that you wish you could study it, but there's no way of studying it because such a world doesn't exist.
Okay, well, thank you. Another question that's come in. So how do you distinguish poor mental health from poor well-being? Could you see a role for encouraging early well-being as a preventative measure against poor mental health?
That's an interesting question. So personally, I actually think of mental health as the umbrella term, and well-being and mental ill health as the two components within it.
Okay.
And there's lots of evidence that mental ill health and well-being are not two sides of the same distribution. So it's possible for someone to struggle with their mental health, so have, for example, depressive symptoms, but still feel like their life is going well in terms of life satisfaction and quality of life, which I think is a really important thing to understand. So if we are able, because if you think about the goal potentially as being that not to eliminate mental ill health, I don't think it's part of the human condition. I don't think we can ever eliminate it. But if you can make a world where the consequences, like where your poor mental health doesn't stop you from living the life you want to live, if that's the goal, then you would argue that actually trying to understand what are the conditions under which, even when you do struggle with your mental health, it doesn't stop you from living the life you want to live. So better well-being would be a useful, I think, way of thinking about mental ill health and well-being. But yes, I think the population approach that I was talking about towards the end, I think is exactly that, which is if you move the distribution, if you focused on well-being, I think you would also move the distribution of distress left, because people would feel generally better. Yeah, so I think focusing on well-being as part of prevention for mental ill health makes sense.
Okay, thank you. So there was another chart that you talked about that showed a really big discrepancy in terms of randomized controlled trials in lower middle income countries and high income countries for younger people. What would be interesting to understand is how some of the results in those two sort of groups diverge, and in the different economic contexts. What are the kind of ways in which results differ from what you've seen?
That's so treatments are not like my expertise. I don't actually do randomized control. What I really wanted was a chart that looked at how, like, more the epidemiology of mental health in low and middle income countries versus high income countries, except there's so little that I don't think that nobody has done like a scoping exercise that was equivalent of non-treatment research in low and middle income countries. But from what I know, because that's my area of research, so how mental health develops, what are the causes, consequences, that I think if we had a chart like that split by high income and low income countries, it would look even more stark than the RCTs. Because when research is done in low and middle income countries, it tends to be treatment RCTs. From the little I know, I think there is some evidence that not all treatments that work in high income settings translate directly to other settings, which I shouldn't come as a surprise. I think that's true in lots of different disciplines. Yeah, but I don't know specifics enough to give examples.
Okay. So you talked a bit about the sort of the importance of thinking about prevention and seeing whether you could shift the curve to the left. So what? And you kind of hinted at some of the measures and interventions, but if you were in charge of government and you were a setting policy and designing interventions, which are the ones that you think would be most effective at addressing the issues you've raised? So this is your chance to be sort of Keir Starmer equivalent for the day.
Oh, I think that is really difficult, because lots of them, I think because mental health is so complex, I think but I think the way to think about this challenge is every part of government could probably do something, right? So if you housing into, I think better, more quality social housing, or, affordable housing would make lots of people's mental health better transport links to improve social connections. If you're justice, better, more, reduction of violence against women, I think, given the example I gave, would have a real world impact on mental health. If you were Department for Education, I think things to help improve school environments and school climates, and also sort of more resources for schools to support young people's mental health, because all children are there. That's a great context for prevention. So I think, and if you were if you were Department of Health, I think just lots more money for mental health, because although it is leading cause of disease burden, the NHS budget that goes to mental health is tiny compared to physical health. And then the thing that always shocks me as somebody who's interested in young people's mental health is, although we know that 80% of difficulties start in child and adolescence, actually only 10% of the mental health services budget goes to children and young people's mental health services. So really what we do is we wait for people to get worse, get older, get worse, and then we provide mental health services rather than having a lot more services for when problems start arising. And I think lots of evidence that earlier in the course of the disease, earlier in life, are the most effective for treatment and prevention. So if you were health, I think lots more resources for child and adolescent mental health. So I think, yeah, it depends on which government department you put me in charge of, what I would do.
A very good answer. And that is staggering. The sort of the particularly in light of some of these growing challenges around waiting lists, particularly for adolescent mental health services as well. It does show that sort of throw that into stark relief. So, do you think that growing awareness of mental health conditions has contributed to the rising number of people affected by poor mental health?
It's an interesting question. So there's ways of thinking about this question. So it's possible that stigma reduction around mental health is why more people are happy to report poor mental health. In which case, it still then begs the question whether then the trends are misunderstood, but it still means lots of young people are struggling with their mental health. It's just they might have been struggling 50 years ago as well, and we just didn't know. But the other way to think about it is consequences, right? So as I said, the reason adolescent mental health, obviously the suffering it causes to adolescents then, but also there's lifelong consequences. And those lifelong consequences, if it was just a reporting thing, so if teenagers today were just reporting more difficulties, but it didn't impact their lives in real ways, you could say, okay, it's just a reporting thing. But what we actually see is that not only are they reporting more mental health difficulties, they're impacting their lives at least as much, if not even more for some outcomes, which suggests that like the real world sort of consequences of these things aren't getting better. So if it was just a reporting thing, I would have expected the consequences to be getting better because people are reporting more difficulties, but the lifelong impacts are less, except they're worse. So I would actually argue that the evidence we have for that argument are actually very poor right now. There's a lot in the media and stuff about this, and there's a lot of qualitative evidence. And obviously, that is very helpful to understand how some people feel about it. But on the whole, I think generally for mental health, especially if you take a global perspective, stigma is still a real problem in many countries of the world. And I don't think we've reached a place where the stigma problem is solved. And now just everything we see is people just being reporting because the stigma has disappeared.
Okay, thank you. So this is a question that you've touched on already a bit, and you talked about the kind of distribution of funding and the level of support and the kind of measures that you could see that might make a difference in terms of housing, in terms of funding, in terms of sort of education provision and engagement. But why don't you think governments try and do more to address mental health issues in their populations? Given how big an issue you've described this as being and the kind of the health burden this causes, how come this isn't getting even more attention? What do you think's stopping it?
So I think probably a lack of understanding of how big a problem it actually is partly to blame. People are always surprised when they hear that actually most people suffer from diagnosable mental health condition at some point in their lives. And I think other problems is understanding impact and valuing it. So lots of times the way in which we sort of quantify the impacts of poor mental health on society tend to be in the terms of sort of healthcare resources used and absenteeism from work, so economic costs of. But actually, if you really could capture better with all the ways in which poor mental health affects our lives and affects the people we love and their lives, I think you would really understand the costs of this better, and we don't have a good way of doing that yet. So I think part of it is we have to get better at quantifying what the impacts mean to people's lives, so that governments can care more. But I think also generally parity between physical and mental health has always been an issue. It looks like it's getting better in some countries, but in lots of the world, physical health conditions are still prioritized over mental health conditions. And the quicker we can see that actually it's all linked and it's all health, I think the more likely it is we will do things to change this.
Thank you. I've a couple of other questions have come in, and then I will draw things to a close. But this has been really interesting. So someone has asked, I've seen a few studies that find better mental health reported by people who are sort of in minority groups. Could this be due to reporting, or is there something else going on?
I think that question would have to be more specific, because it would depend on which groups and which country and which.
Okay.
It could be. There might be contexts in which being a minority in a minority group is not. And I just showed an example of that as well, right? So in South Africa, if you identify as being of white ethnicity, you are in a minority group, but you have better mental health on average. But in that context, white groups have much more political, economic, and social power as well. So yeah.
Very context dependent.
Very context dependent.
Okay. And then how much do you think activity limitation, say because of disability, living conditions, or economic factors, negatively affects mental health?
I think this is really context dependent, right? So if it depends, I think, on the type. So I think this is a good example of where the environment, social and policy things can really change what living, for example, with a disability might mean in a certain society versus another, and then hence its impact on mental health. Again, I think very context dependent, but generally, if you could create a world in which living with a disability or a certain condition, but you can still go about your day-to-day life, have opportunities, and so on and so forth. Obviously, that is better for your mental health than if you live in a society or a policy environment in which that's not the case. Yeah.
Okay. I think possibly one final question to wrap it up, and then I'll bring it to a close. So there's been quite a lot of talk about the pandemic being something that's particularly in the context of the UK and press and things like that, being a cause of poor mental health in populations. What would your answer to that be?
I think, like any large sort of, the pandemic was like a big sort of public health event, and all the evidence we have suggests it did worsen population mental health slightly, but the worsening generally was happening for decades previously, as I've sort of tried to illustrate. So it created another bump in population, and obviously there was the mental health consequences of COVID-19 infection and disease itself as well. There is some evidence that those increases were significant in terms of population health, because even a small effect size at a population level means a lot of people. But it sort of, yeah, it's just like another bump up from something that has been increasing for a long time. So I wouldn't blame only the pandemic for the current mental health sort of
so
it's
it's had an impact, but it was on an upward trajectory anyway.
for a long time.
That's really helpful. Okay, well, I just wanted to say thank you very much. That was great, really interesting, and I've learned a lot personally. And I wanted to say to everyone else that's attended, I think we've had lots of people online viewing this. Thank you very much for attending today's lunch hour lecture. If you would like to take part in the current World Mental Health Day Workplace Health campaign, or if you would like to stay up to date on future campaigns and informations, links will be sent out after the event. And finally, the next lunch hour lecture, the last one, is due to take place on the 17th of October, and this is going to be focused on the antidepressant controversy. So thank you very much again, Pravita. Great to hear from you, and thank you very much, everyone. I'm signing off now.
Thanks, everyone. Thanks, Sam.